How much is the risk of fat embolism in these different procedures?
So, sir, that would need an entirely different presentation for that. But for that, I think anatomy is most important. On face, there are few danger zones. Like one is in the glabella, one is around the nose, one is in the infraorbital rim, one is around the nasolabial fold. So one is in the temple. So there are 6 different facial zones, danger zones. So if you know your anatomy, the placement of the arteries, in which layer they are located, so probably the chances would be less. Okay, but I agree these 6 areas, they do have an anastomosis with ophthalmic, with that central retinal artery, internal and external carotid artery. But if you know the location and depth of the vessels, probably the chances are less. But there are reported cases of fat embolization. But you should know your anatomy.
What is the difference between microfat and nanofat?
Okay, excellent question. I think we would be discussing this, but I will just tell you that microfat is with which cannula you have harvested the fat. For example, if you are using 2.7 millimeter cannula with 2 holes or 3 holes, large holes, so you are harvesting microfat. There would be globules of the fat that won't be much bigger, but they won't be like a liquid. For macro fat, you need a larger bore cannula like 4 millimeter with larger holes. So large globules of fat will come. And for nano fat, what we use is that we use multiple small holes, 12 holes in a cannula, small holes, when you will harvest that fat. So the only kind of, I would not say liquid, but near to liquid fat would be harvested. There won't be any septa. So this is basically the size of the globules, the size of the cannula that determines the type of fat graft you are harvesting. So it is macro, micro and nano. I think Dr. Abbas would be talking about this. Yes, he would be discussing this in detail.
सर मेरा भी क्वेश्चन है कि जैसे आपने कहा कि डिफेक्ट्स में जो है पहले हमें कहा जाता था कि आप ज़्यादा फैट को करें और जो है आप प्रैक्टिकली जो है आपका अपना क्या एक्सपीरियंस है, आप उसको थोड़ा अंडर रख के करते हैं या डिफेक्ट जब कंप्लीट हो जाता है आपको विजिबली आप उसके ऊपर छोड़ देते हैं उसको, और जैसे आपने मेंशन किया कि आप एसडीएफ के साथ करते हैं तो उसका रिजल्ट एक ही सिटिंग में वो 2 years के ऊपर इतना अच्छा है ऐसा, तो आप क्या अपना
प्रैक्टिकली देखिए, प्रैक्टिकली if you should add towards underfilling, I would suggest, okay, for a neighbor, for a novice, instead of going little bit over, I think it's better to underfill it, because fat is going to absorb if you just a fraction of it is overfilled, because there will be tight compartment, blood supply has to come from the surrounding. So practically what we do is that we try to achieve symmetry as much as possible with the opposite side if the compliance of the skin is good. But if compliance is not good, we are just doing 2 or 3 sessions just to improve the compliance of the skin. So this is what we are practically doing. The cases I have shown you where there is tight skin, so there would be only 3 or 4 sessions just to improve the compliance, and then we will be doing sessions for correcting it. But it is always err towards under or just optimum. This the experience will tell you.
Dr. Mustehsin, I'm Dr. Mahmood from New Hospital. I want to ask you what advantage we have with reference to comparison between fillers and fat grafting.
Okay, so there is a long comparison list if I start, but in brief, obviously you all know that fat is an autologous tissue, and if it takes, it would stay for life. For example, if it takes 70% fat graft take is there, it would stay for life. It has more regenerative potential. On the other hand, for fillers, obviously you don't need any donor site. Okay, you just need an injection and you have to put it there. Obviously, there are chances of absorption of fillers And then there are about certain areas. For example, in tear trough, I have abandoned use of fillers in tear trough. It is always better to inject fat there. But there are other areas where you can always use filler, keeping in mind the patient preference and its ease. But in comparison, in nutshell, autologous tissue is always better than something not native to the body.
What about the cost? Cost effective, which procedure is cost effective?
Like in these patients which I have shown you, probably the cost of fillers would be much higher. Okay? Because much more filler would be needed for these contour deformities.
Any study or data public that where scissors and PRKs have been given together? And
Yeah, so this is an interesting question. I think now people have started using mixing fillers with starting from lignocaine, starting from quiescence fluid and going up now to PRP, to nanofat. Yes, there are. But practically speaking, I don't think any advantage of that, because you are taking the donor site, you are using a synthetic filler and then you are mixing it. Practically speaking, I don't think there should be any logic behind it. Except for if you are harvesting fat, you can harvest more fat. I think Professor Azim Jahangir want to comment on it. Sir, please.
There are two comments. One is about the central retinal artery. Most of the studies that were published in 80s from Korea, they were of the view that because they use the needle action to inject the fat. So suggestion would be never inject the fat on the face near the eye, very orbital area with the needle. We have blunt cannula.
Yeah.
We have like 2 or 3 millimeter cannula and we can do this. As long as you are using blunt cannula, the chances of injecting the fat into the artery is extremely low. The other thing is don't inject it with a lot of pressure, because as doctor told you that overfilling probably causes the pressure necrosis. Just like we see a lot of pressure necrosis on the bed soles. The same concept. Because if you are putting a lot of pressure, it means that you are causing the pressure necrosis. For your question that how can you compare it? If somebody is going to need more than 2 or 3 cc's of filler, which is going to cost 40,000-50,000 rupees, it's much cheaper to inject the fat. And if somebody is having a lot of area to liposuction on, so rather than doing the liposuction and throwing that into the garbage and then putting an implant on the breast, you can actually just do the lipotransfer, you can do the fat transfer. And interestingly, as doctors have told you that since we have been using it for a very long time, not knowing that there were stem cells, we have seen repeatedly that after you do the fat transfer, first 3 to 6 months it goes down and you lose 30 to 50%, even up to 70% fat. But interestingly, when the same patient comes second year, they start to claim that their filled area has started to increase. And we didn't know, honestly, many years ago, when I was doing a fellowship in America about 20 years ago, that what was the reason for that. Now we know that we were inadvertently injecting fat cells. So I think where the filler is needed in large abundance, then I think more than 2 or 3 fillers, then it's much cheaper to do the fat transfer.
Yeah. And I fully endorse the point of using the blunt cannula. So first is your anatomy, your basics. If you know the plane, if you know the location, and then over the blunt cannula. I fully endorse that.
I want one thing clarified from you. You said that once you take a tissue and put it in a dish and grow it, then it has ethical and legal issues. What does that mean?
Professor M.B.B.S, would you like to comment on it? वही क्वेश्चन जो हम लोग डिस्कस कर रहे थे कि once the cell is in the petri dish, so what are the ethical issues?
Ethical issues इसलिए नहीं है, जब जो हमारे ह्यूमन ऑर्गन की होता है, जॉब होता है, वो एक्चुअली जब आप कोई कल्चर करते हैं तो उसको एलोजेनिक कंसीडर करते हैं। जो SVF है उसको ऑटोलोगस, लेकिन जब आप कल्चर में आते हैं तो फिर उसमें वो एलोजेनिक कंसीडर करते हैं। एथिकल प्रॉब्लम्स में हमारी ये
सर एलोजेनिक से तो फिर एथिकल शुरू होंगे ना सर, इट बिकम्स एलोजेनिक टिश्यू ट्रांसप्लांट, then you have to take the consent, you have to prove your center and all those things which are associated with renal transplant or organ transplant. Once it becomes allogenic, your own fat is being harvested, taken to the lab, expanded. Once it is expanded, then it is your own fat. It is allogenic. So for that, you need to have ethical approval and you consider it as an allogenic tissue transfer or tissue transfer. So those are the.
एक और डॉक्टर है, इसमें एक और क्वेश्चन ये प्रॉब्लम ये होती है कि जब आप इस टिश्यू को ग्रो करना चाहते हैं लैब में, तो ट्रेडिशनली वी हैव बीन यूजिंग बोवाइन सीरम। अब बोवाइन सीरम में जिसने आपने सुना होगा पुराने जैसे कि इसमें वायरस होते हैं, तो दैट वाज अ मेजर इशू। नाउ दैट वी कैन यूज द सेम पेशेंट सीरम एंड ग्रोइंग द, तो इसमें ट्रेडिशनली जो प्रॉब्लम थे वो कम होते जा रहे हैं। But the problem is when we are starting to manipulate human organ, even from the same person in the lab, the chances of getting infected and stuff like that. That's why हम लोग कहते हैं कि GMP होनी चाहिए, approval होनी चाहिए, तो इस तरह की चीजें। लेकिन मेरा ख्याल है ना सिर्फ ethical issue, इसमें scientific issues भी थे, right?
And it can become an illegal activity.
Yeah, I think we can discuss it on a cup of tea and thank you very much. Thank you.